We now move on to our second scientific session of the day, starting with Dr. Sahana P Raju, Assistant Professor of Dermatology at Bowring and Lady Curzon Hospitals, Bengaluru, presenting her insights on infantile hamangioma, current perspectives, and treatment strategies. Over to you.
Right. Good evening, everybody. So I hope all of you enjoyed your cup of tea. So at the offset, I'm very grateful and thankful to Dr. Sandeepan sir for believing in me and for giving me this wonderful opportunity. So today I'll be talking about infantile hemangiomas, the basic concepts, current perspectives, and treatment strategies. So before we dwell into the topic, so we need to know where infantile hemangiomas stand. So this is a classification from the International Society for the Study of Vascular Anomalies. So they basically classified vascular anomalies into tumors and malformations. Further, tumors were divided as benign, locally aggressive, and malignant. So infantile hemangiomas come in the benign category of tumors. In fact, it's the most common benign tumor of infancy, and it develops in 4 to 5% of the infants. So the first diagram which I have portrayed, that it was previously thought to be a disorder of angiogenesis. So there's a big difference between angiogenesis and vasculogenesis. Angiogenesis is the growth of blood vessels from already pre-existing blood vessels, whereas vasculogenesis is the de novo formation of blood vessels. So it is changed from a disorder of angiogenesis to a disorder of vasculogenesis. So these are the risk factors, like there are certain infants who are predisposed to the development of infantile hemangioma, female with low birth weight, preterm history, and a family history. There are a lot of antenatal risk factors as well, like the use of Coriolis villus sampling, in vitro fertilization, a lot of maternal risk factors like gestational diabetes and hypertension. The reason why all these are associated with the formation of an infantile hemangioma is they cause placental hypoxia, which leads to fetal hypoxia. So this is a very common theory which can explain the development of infantile hemangiomas. I'll not go into a lot of details. The most popular ones are the placental theory and the hypoxia theory. So what we need to remember is there is a growth factor called as the vascular endothelial growth factor, the VEGF, which is responsible for the formation of blood vessels. The placenta produces a soluble form of this VEGF receptor called the SFLT1. So as we can all understand, in the postpartum period, there is no placenta, no SFLT1, and there is unopposed angiogenesis. The tissue hypoxia theory, like I already said, a lot of antenatal risk factors which cause tissue hypoxia, and this leads to the formation of infantile hemangiomas. Again, this is a very complex diagram which shows a lot of cytokines and growth factors involved in the development of hemangioma. We'll just skip this. So they're basically classified based on the depth and on the morphological subtype. So based on the depth, they can either be superficial, so this is a superficial, or it can be deep, or it can be a mixed. So superficial hemangioma presents as bright red papules and plaques, which are mainly just thin superficial lesions, and they are non-pulsatile and non-tender. So here you can see a deep hemangioma, which is more into the deep dermis and subcutaneous tissue. And mixed hemangiomas have components of both, superficial and deep components. So that was based on the depth, and this is based on the morphology. It can either be focal, segmental, or it can be multifocal. So focal is just a single solitary nodule. Segmental, it follows a certain anatomic area. And multifocal is multiple numerous single lesions. So it's important to know about these types because the treatment varies and also the prognosis is different. So there are certain precursor lesions that when you see these lesions in an infant, and the infant also has certain risk factors, you always have to rule out infantile hemangiomas. The most common one is this area of pallor, or this bruised and this blanched appearance, So the other precursor lesions are bruised appearance, telangiectasia. So when you see these lesions in an infant, it's always, you have to suspect that this child might develop infantile hemangioma in the future. This is a graph which shows the natural history of infantile hemangiomas. So there are three phases which any infantile hemangioma goes through. There is an early proliferative or growth phase, then there is a plateau phase, and then there is a involution phase. So the early phase, so infantile hemangiomas are usually not present at birth. So to answer Manas sir's question in the last discussion, this is again a very complicated graph. If you can concentrate on the red line, infantile hemangiomas are not present at birth. They start growing after birth. They grow up to 9 to 12 months of age, and then they slowly start involuting. So if you can see the red line here, okay, so the blue line is a vascular malformation, which is that vascular malformations are already present at birth and they usually do not involute spontaneously, whereas the infantile hemangiomas undergo spontaneous involution. Right. So this is the typical progression of an infantile hemangioma. This is at birth and this is at 2 years of age where there is complete resolution of the lesion. So here, as you can see, the lesion becomes milder in color from dark red to these are just areas of telangiectasia, and here you can just see an area of hypopigmentation and it completely disappears. So this is the histopathological finding where in a proliferating hemangioma, this is a smooth muscle actin stain which was done. So in a proliferating hemangioma, you can see multiple vessels. And in an involuting hemangioma, you can see that these vessels have become lesser in number, they have enlarged, and the fibrofatty tissue has also dissolved. And the last picture is a completely involuted hemangioma where there is absolutely nil vessels. So this is a special subtype of infantile hemangioma called infantile hemangioma with minimal or arrested growth. So this was a 3-month-old baby who presented with this erythematous telangiectatic rash. So this typically doesn't look like an infantile hemangioma. So because of the family's anxiety, a biopsy was performed and it showed GLUT1 positive vessels. So GLUT1 is a receptor which is very common, which is very specific to the infantile hemangioma. So this subtype is something which is uncommonly seen, mainly for the dermatologist. So if you're suspecting infantile hemangioma and it doesn't look like one, you can always do a biopsy and do an immunohistochemical stain for GLUT1. So there are a lot of activity scoring systems which we use, not mainly used in clinical practice. These are all used to assess the therapeutic effects of oral propranolol. So the most commonly used one is called the hemangioma activity score. Here we use a very subjective parameter, that is color. So I'll just show you a few images where all of them are infantile hemangiomas and they're all scored according to the scoring system. So this is a tense deep swelling and this is a shiny red hemangioma. This is hemangioma with a bright red edge. So this is a deep purple. This is blue shining. This is a gray hemangioma and this is ulcer in a hemangioma. Again, it's not routinely used in clinical practice. We use this scorecard to monitor the effects of oral propranolol. So coming to the complications of hemangiomas and when do we treat and when do we not treat. So the complications can be local, regional, or there are systemic complications. So the local complications are ulceration, hemorrhage, infection, and necrosis. The regional complications can be according to the site. Like for example, the hemangioma which is in the periorbital region can cause a lot of visual complications. An auricular hemangioma can cause hearing loss. A hemangioma which is in the beard area can cause life-threatening airway complications. Just to give you examples, so this is a hemangioma which is very close to the eye and it absolutely has to be treated. Again, this is a hemangioma at the tip of the lip and this can cause severe scarring, disfigurement and ulceration, so these have to be treated. So these are some of the systemic complications of multifocal hemangioma. So this is just to explain how a small infantile hemangioma can cause something as serious as cardiovascular complications. I'm sure all the pediatricians here will be able to explain it better than me. But in the fetal stage, the fetal circulation is different from the the circulation of an infant. So there is high pulmonary vascular pressure and which gradually decreases once the baby is born within 3 months. So the presence of an infantile hemangioma actually increases the load on the right side of the heart and this can cause congestive heart failure and pulmonary hypertension. Again, how can something as small as an infantile hemangioma cause hypothyroidism? So this entity is called as consumptive hypothyroidism. It's a rare scenario where there is overexpression of an enzyme called as deiodinase. So why I'm telling you about all these things is you should suspect visceral hemangiomas when there are more than 5 small cutaneous hemangiomas. So the current guideline is to do an abdominal ultrasound to rule out visceral hemangiomas if there are more than 5 cutaneous hemangiomas. So again, investigations, imaging of infantile hemangiomas is generally not necessary. Like I already said, only if you're suspecting a visceral hemangioma, USG is the preferred modality. MRI also can be done. So we do a bronchoscopy in case of beard and laryngeal hemangiomas. And we also do an ECG if you're suspecting underlying syndromes or you're suspecting cardiac involvement. Okay, so coming to the management of infantile hemangioma, so what should be done? The most common thing which we do if it is an uncomplicated single small hemangioma which is not in any area, high risk area, like it's not in the periorbital region, or if it's just a simple small hemangioma lying on the trunk, we don't do anything. So that is the wait and watch or the active observation. But there are a lot of studies which say that early intervention is required to arrest the growth of the lesion and reduce the associated complications. So active observation is what should be most commonly followed in uncomplicated hemangiomas. Then there are topical and systemic treatment for large hemangiomas which have a low risk of disfigurement with high risk, mixed or deep hemangiomas and segmental. All of these things have to be treated. This was the earlier treatment, the steroid era, 1960s, where systemic and intralesional corticosteroids were used in the management of infantile hemangioma. So corticosteroids inhibit both angiogenesis and vasculogenesis. So it was used in an oral form where we used 1 milligram per kg body weight for several months, and we also used an intralesional corticosteroids where, but again, all these are associated with high risk of adverse events, and in spite of their efficacy, systemic corticosteroids are no longer used by most of the dermatologists as first-line therapy due to the associated risk of adverse effects. This was the American Academy of Pediatrics clinical practice guidelines for the management of infantile hemangiomas. So they talk about 5 aspects. So there is a risk stratification, like is the hemangioma complicated or uncomplicated? Should you treat it or not? When should you do imaging? When to treat and with what to treat? So they recommend medical, surgical and lasers. So the AAP recommends that when systemic treatment is indicated, oral propranolol is the drug of choice at a dose of 2 to 3 milligram per kg per day, and topical timolol can also be used to treat small, thin and superficial infantile hemangiomas. So this is the recommendation, and they recommend surgery for the treatment of residual skin changes. Like I had a previous slide which shows residual skin changes like fibrofatty tissue and pigmentation. So surgery and lasers are mainly indicated for that. And the most important thing is parent education and counseling. Coming to propranolol. So this was a serendipitous discovery where a child of HOCM was treated with propranolol, and they also observed regression of the facial hemangioma. So it was FDA approved in 2014, and the main mechanism of action is vasoconstriction due to decreased release of nitric oxide. It was found to be more effective when started in the proliferative phase, but we use it to treat hemangiomas in any stage after understanding its efficacy. So the indications are, like I said, the indications for oral treatment of hemangioma is only in a high risk complicated hemangioma. So if it is in the periorbital area, if it's at the tip of the nose, lips, anogenital region, because all these are high risk areas for ulceration. If it is a large proliferating infantile hemangioma, multiple and segmental. So these are all the indications for starting oral propranolol. So the optimal time for initiating treatment is as soon as possible. We use it in any age above 4 weeks. If we don't use it in the neonate, so post-neonatal period, propranolol can be used. It should be given for a minimum period of 6 months before you discard it and you shift to something else. Ideally, till when should oral propranolol be used? Until there is complete regression, but we don't follow that anymore. At least until the end of proliferative stage or until the hemangioma starts growing. which is 9 to 12 months of age. That is till when we administer oral propranolol. So the basic things which we ask the patient is a history to rule out any underlying heart disease like heart murmur or family history of heart block and arrhythmia. And we also ask history of wheezing, dyspnea, tachypnea to rule out any underlying bronchial asthma. Then we do a physical examination of pulse and blood pressure. So pulse and blood pressure are measured at baseline. They're also measured in the first and second hour because that is the time where propranolol most commonly causes bradycardia and hypotension. And blood glucose levels because hypoglycemia is one of the most common and dreaded complication of oral propranolol. So dosages, the FDA recommends we begin at 0.6 milligram and after a week we increase it to 1.1 and then after 2 weeks we increase it to 1.7. But the regime which we commonly follow is 1 milligram per kg per day for the first week, 2 milligram in the second week and 3 milligram in the third week. Again, treatment duration, how fast is the effect of oral propranolol? It starts as early as 24 hours. You can see the infantile hamangioma becomes softer and color becomes lighter within 48 hours. There is progressive flattening and fading of the color. The parents are explained in detail about symptoms of hypoglycemia like shivering, sweating, and they are asked to follow up immediately. Otherwise, we ask the parents to follow up every 2 weeks. Also, most of us, I think most of the dermatologists treat if required on an outpatient basis, but we also admit the patient in case of complicated infantile hemangiomas or any syndromes do require admission. Otherwise, they are treated on an outpatient basis. So this is Sandeepan sir's patient. This was a 3-month-old girl who had this large facial segmental hemangioma with a central ulceration. And this child was treated with oral propranolol, 3 milligram per kg per day. So you can see the result in 3 months of treatment. 6 months of treatment, almost 75 to 80% of the hemangioma has regressed. And at 12 months, there is complete regression of the hemangioma with mild telangiectasia and mild fibrofatty tissue. Otherwise, there's almost 100% resolution of the hemangioma. So the side effect, the most dreaded one is hypoglycemia. So this was an article which was published in IJPD by Dr. Manish Shah, which says how to administer propranolol and how do we prevent hypoglycemia. So you administer it only during daytime. You administer it after each feed. Give frequent feeds to the baby and give a minimum time of 6 hours between each dose. Again, this is something which we give handouts to the parents to avoid hypoglycemia. The other complications are hypotension, bradycardia. Again, the bradycardia is very important to monitor because the heart rate varies with the age. Like infants, the normal heart rate itself is 120 to 140. So bradycardia for age. And I also palpate both the femoral pulses because it's contraindicated in coactation of aorta. Sleep disruption, diarrhea, acrocyanosis, caries, these are all the side effects of oral propranolol. The contraindications, like I said, any underlying heart condition or any underlying respiratory condition. Otherwise, neonates 0 to 4 weeks of age, hypersensitivity and drug interactions. So the other medical modalities which other than oral propranolol, other beta-2 blockers like oral nadolol and atenolol. So both these are selective beta-2 blockers which have the same efficacy as oral propranolol but lesser adverse effects and a longer half-life. Again, there are no large RCTs about these. This is something which is new. Timolol is a non-selective topical beta antagonist. So it is FDA approved for and already available for the treatment of pediatric glaucoma and a lot of ophthalmic indications. So we have 0.25% and 0.5% strength ophthalmic drops, and the dose is 2 drops per day. Twice daily for around 12 to 24 weeks. And the indication for this is small superficial infantile hemangiomas which don't require systemic treatment. These are the only scenarios where we can think of topical timolol. So the advantages are they're readily available, ease of administration, and there is no risk of drug-related adverse events. The other drug which is also used topically is the imiquimod. So this is applied 3 to 5 nights a week for a period of 16 weeks. So there is another entity called as a propranolol resistant infantile hemangioma, which is when you give propranolol for a minimum period of 4 weeks and there is absolutely no change, or the hemangioma keeps growing or it doesn't involute. When you give propranolol for 4 weeks at a dose of more than 2 milligram per kg, then we term it as propranolol resistant infantile hemangioma. This was a case report in which it was treated with this mTOR inhibitor called as sirolimus. So image A is the child when the child presented, and C is on treatment of propranolol. You can still see there is growth of the lesion, and this is when the child was started on sirolimus, and then you can see the regression. Sirolimus, again, no big randomized controlled trials are available. The other treatment modalities, miscellaneous ones, are pulse dyed laser only for cosmetic outcome. We also use sclerotherapy and surgery, excisional surgery and embolization. Some recent advances, there was a case report of sandwich therapy, which is a combination of medical and surgical modality. Bleomycin was injected intralesionally before surgical excision and after surgical excision to reduce the recurrence of the lesion. And there is also a topical propranolol which is coming into play. So the take-home messages are, when do we investigate? Only imaging is only necessary if you suspect an underlying syndrome or if more than 5 cutaneous lesions are present. When do we treat? If it is located in a site which is very risky for ulceration or any systemic complications, only then it is treated. Otherwise, we wait and watch. The first line drug in complicated at-risk infantile hemangiomas is oral propranolol. Corticosteroids we don't use anymore. The things we have to watch out for is measure the pulse and the blood pressure in a timely manner. And topical timolol is also something which is coming up in a big way. Thank you.